Good afternoon and welcome to today's webinar, Tackling Tough Public Health Problems Through Cross-Sector Data Collaborations, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Strong, the Digital Marketing Coordinator at the Network for Public Health Law's National Office, and I'll be your host for today's webinar. Please feel free to submit questions at any time by using the Q&A tab on the right-hand side of your screen. We strongly encourage attendee participation in our webinars and would love to hear some of the thoughts and questions that you have. All you need to do to submit a question is click on the Q&A tab, select all panelists from the drop-down menu, and submit your questions. If you do not see the Q&A tab available, click on the button with the 3 dots highlighted in the picture. Your moderator/presenter for today's webinar is Jennifer Bernstein. Jennifer is the Deputy Director of the Network for Public Health Law's Mid-States Region Office, where she provides information and technical assistance on issues related to public health. Her work focuses on public health data, adults at risk, maternal and child health, and statutory and regulatory public health. Jennifer will be leading us through the rest of today's webinar. So Jennifer, over to you.
Hi, thank you, Charles. Okay, so I'm going to introduce the other 2 speakers now, and then I will give a brief overview of what we're going to be discussing and then pass it on to our speakers. So after myself, we will then hear from Kaysen Schmidt. Kaysen is an assistant professor at the Department of Health Policy and Management at the Texas A&M School of Public Health, where he actively researches the role of law in health systems. The principal focus of his research is the role of law in the promotion of health information technology, including state health information technology legal frameworks, health information exchanges, and telehealth. He is actively studying the ethics and impact associated with differences in federal and state laws, protecting privacy and confidentiality in health, education, social services, and commercial settings in the age of big data. And then after we hear from Kaysen, we will hear from Kathleen Kelly. Kathleen earned her Master's of Public Administration from Rutgers University Camden after working for several social justice nonprofit organizations. Her focus was community development, and she served as a project assistant at the Senator Walter Rand Institute for Public Affairs, building a community coalition for youth diversion. She brought this experience to Peoria, Illinois, where she worked as a management analyst for the Peoria Police Department, building community partnerships to address social determinants of health through collective impact and crime reduction strategies. So I want to just lay a foundation or a framework for our discussion today. So I want to lay a foundation for what we're going to be discussing today and paint a picture. So they're out there in the world, and we're just talking about public health data, but there's so much data that exists. There's screening data, which includes things like childhood-led and newborn screening. There's WIC data. There's regulatory information that public health collects through restaurant inspections and licensure and other functions. There's also health plan data that public health collects through Medicaid and CHIP and other programs. Vital records and registries, as well as disease surveillance information. Clinical services, an often overlooked function of public health, immunizations, school-based clinics, or FQHCs, and then emergency preparedness data as well that look at volunteer registries and health alert networks. And this amount of data is continually growing. This doesn't include all of the other types of health and environmental data that can affect health. And so we have to think about all of the different factors. So that includes the amount of data and the sources of data, thinking about who our data sharing partners could be, where we can obtain more information depending on our needs, our public health mission, thinking about ways that we can transfer and exchange data as it complies with law, and thinking about when and how we can make linkages with other information and when that is appropriate, creating integrated databases. All of that data that I showed before generally sits in its own siloed registry or database, and so thinking about ways we can integrate information for public health benefit, and also thinking about when we have data, how we retain it, how we reuse it, how we share it, and then also whether or not the creation of public data sets has benefit and creates transparency. And then on top of that, we have to overlay all of the laws that affect data. So these are data protection and disclosure laws, and those are frequently a condition for receiving funding, especially for public health. So on the federal side, things like HIPAA and FERPA, Title X registries, and so on. And we will be getting a lot more of a discussion of these types of laws from Kaysen during his presentation, but also thinking about the state legal scheme and how all states have their own data protection and disclosure laws, and so that could be related to health information, registries, vital records, and so on. And thinking that law is governing every aspect of data, so how we collect it, how we use it, how we share it, and how we protect it. And so this ultimately leads to the question about whether or not law is a friend in these efforts, or if law is a foe. And so does it help us do our job? Is it a legal barrier? I would say probably both, and we'll discuss that more. And then thinking about what those barriers to exchange might be that we come up against. State law, how it applies, as I mentioned, it varies among states, and so it could be difficult to apply it, especially given that state and federal law might not be in harmony. And then thinking about general versus specific authority to exchange data, so whether or not your state has a statute granting specific authority, or if you're using more general public health powers. Also, limited the scope of sharing, so if there are prerequisites, conditions, or limitations on sharing data that's inscribed in law. And then thinking about within a state what the applicability of multiple state laws might mean, and whether or not there needs to be a harmonization of those laws. And finally, the variety and changing systems and the manner of exchange. So technological capability is growing, and with that means growing complexity, and thinking about the multiple ways that data is transferred. And what we say is that every transfer point of data is a decision point for the law. And hopefully not getting too discouraged, and coming up instead with some creative solutions that we can find to help us navigate the law and get to yes with our data sharing. So this could be creating exceptions in agreements that accommodate certain parties to the agreement. It could be meeting legal requirements of the most restrictive parties law. It could be a change in law or regulation to accommodate sharing, or having the party with the greatest authority act as a data clearinghouse. And we'll hear a little bit about this last one when Kathleen speaks about her work in Peoria, having the greatest authority the party with the greatest authority act as a clearinghouse. And so I will now pass this on to Kason.
Thank you, Jennifer, and thank you to the Network for Public Health Law for this opportunity to talk with you all today. Yes, I'm here to talk about this patchwork of federal privacy laws, and you know, if you'll entertain me for a moment, I'm planning on doing this in a different way than I typically do. Usually I jump into these types of presentations and I talk about privacy laws, and privacy, as we know, is one of those topics where there are some very passionate but sometimes conflicting opinions and views, and sometimes deeply rooted into ethical principles. And sometimes these types of discussions tend to bog down the overall discussion more than leading to an understanding of some of the real legal issues. So I'm sort of experimenting here with a different type of outline where I start off talking about some of these ethical issues relating to using existing data for public health purposes. And then after I establish that background, I'm going to talk more about these federal privacy laws in some detail. And maybe what are some of the implications for the framework that we have at the federal level. And then at the end, I'm going to contrast what we have in the United States with an international model, which is the General Data Protection Regulation that was recently enacted by the European Union. I hope after this presentation, you'll have an idea about how different some of these federal data protections laws are in different sectors, and yeah, so let's dive right in. Oh, before I start, this work that I'm going to talk about is derivative of some work I did for the Network of Public Health for Public Health Law, and this might be of interest to the audience here today. Together, we created 22 snapshots of different federal laws protecting data. And these snapshots are not meant to be comprehensive resources to tell you everything that you need to know about different federal data protection laws, but they're meant as a beginning to a path towards understanding what some of these legal requirements are. So they provide you some of the general requirements of the law, talk about some legal requirements and how they might be different from other types of laws, and they provide links to federal guidance and resources. So we're very excited to have those out and hope that they can be a real resource to help people understand this very, very, very complicated framework. Here are some abbreviations of some of the laws and that I'll be covering today. But so let's talk a little bit about ethical foundations for using data for public health purposes. So recently, the World Health Organization spent a lot of time and effort putting together these guidelines, published, I believe, in 2017. And these guidelines apply a public health ethics framework to data use and data disclosures. And that's significant because when we typically talk about privacy and confidentiality, especially in the context of HIPAA, frequently we're looking at a bioethical framework. And where in the example of, say, a clinical trials, we're concerned about the individual research subjects. And so we place a premium on the ethical principle of autonomy and respect for persons to ensure that those research subjects are protected. When we look at a public ethical framework, public health ethics framework, we expand the scope of our focus, and we're looking more at communities and populations. So while we don't let go of this important ethical principle for autonomy and respect for individual persons, we start to give greater weight or increased weight to the ethical principle for social and public good. And so with the release of these guidelines, the World Health Organization balanced these various and sometimes conflicting ethical principles and came up with some useful guidelines to move forward with regard to the use of data for public health purposes. So, interesting, guideline 1, establishes an obligation on the part of governments to conduct public health surveillance. It's saying it's an ethical obligation to collect data and use that data to promote the health of your people. Guideline 11 establishes a justification for collecting identifiable data. So not only are we collecting data, but sometimes it's ethically important to know the identities of those individuals whose data you are collecting. And Guideline 12 says that under certain circumstances, informed consent is not ethically required. That we can collect this data and we can use this data for public health purposes, and it's not ethically required to ask for the informed consent of those individuals. Guideline 14 establishes an obligation for governments to share data with public health. Guideline 16 says that under certain circumstances, it is ethically permissible to use data for research purposes. So the purpose of kind of going through some of these guidelines is not to say that, yes, we need to collect all data and we need to use all data for public health purposes, but it's just to acknowledge that under some circumstances, there exist some circumstances and some facts that allow data to be used and disclosed for public health purposes, sometimes identifiable data, sometimes data that is used without the informed consent of the data subjects. So in this context, let's transition to the federal legal framework. We know that federal agencies collect and use data for varieties of programs and initiatives, and these are across sectors, right? Even though a lot of this data is collected outside of this umbrella of public health, it still has significant potential to inform public health activities. Unfortunately, there are just a huge variety of different federal data protection frameworks, and these vary depending upon 4 major factors: the person or entity involved, the nature of the data that is collected, used, or disclosed, why it was originally collected in the first place, and what we are intending to do with it now. And if one of those factors is different, we may be looking at a different federal privacy framework or a different requirements at play. So here are the 22 laws I'm going to be talking about in the next couple of slides. And I'm going to start by breaking these laws down on common elements to hopefully more clearly communicate some of the differences that we see between these different laws. So in this chart, we are looking at how these different frameworks are defining identifiable information. Why is this important? Well, many federal laws only attach legal protection to data that's identifiable. So to know what that means, we look to the definition within the law. As you can see, just from the distribution of X's or in colors here, that there really isn't any consistency with how laws are defining identifiable information. There are some laws that simply do not define what is and is not identifiable. There are some laws that are particularly unhelpful, and they say that identifiable information is information about individuals, which it's difficult for me personally to wrap my head around, but conceivably, information about individuals could mean any person-level data that, for example, data that's not aggregated, regardless of whether or not it has names or other identifiers associated with it. Some laws use combinations of direct identifiers, such as names, social security numbers, and indirect identifiers, such as date of birth, zip codes, race, age. Some laws use a standard that relies on some element of deduction or inference. And I'm going to talk a little bit more about that on the next slide. But similar to how laws define identifiable information, an area of particular interest in both academic and public health areas are how can we take data that is protected and render it such that we can disclose and use that data in a legally permissible way. And so we have a de-identification standards. How can we take identifiable data and legally, under the eyes of the law, transform that data into something that we consider legally de-identified? And as you can see, very few laws that we looked at here have standards within them that will allow individuals or entities to de-identify that information at the person level. Quite a few require summary or aggregate information in order to consider information not identifiable. So let's talk about the deduction and inference. Here are some major privacy laws that are commonly cited. And we see that each of these four examples uses language that requires some sort of deduction or inference. For FERPA, it's information that alone or in combination is linked or linkable to, that would allow a reasonable person to identify the student with reasonable certainty. 42 CFR Part 2, information which can identify a patient, which the identity of a patient can be determined with reasonable accuracy. HIPAA, there's a reasonable basis to believe information can be used to identify. SIPSIA, identity can be reasonably inferred by either direct or indirect means. Now, as attorneys, we are often pretty comfortable with this language about what is reasonable. We've all got in 1L torts hammered with this idea of a reasonably prudent person. We're pretty comfortable with these standards that rely on what is and is not reasonable. We call them objective standards. But in reality, these are actually really difficult standards to apply in practice. In law, we resolve these standards through litigation. We get two adversarial parties in the same room. We argue at each other for over a course of several days, And then we put 12 people in a box whom together we assume make one reasonable person who can evaluate whether or not something is reasonable. This isn't a practical way to resolve issues if you are a data custodian and you're trying to think about whether or not it's appropriate to release some data under a squishy standard like what is and what isn't reasonable to determine. A data custodian is an expert, often an expert in data use or data science. And so what they perceive as what is reasonably and not reasonably possible to identify might not be the appropriate standard to apply. And I think this is one of the reasons, the difficulty applying these standards is one of the reasons why we see sometimes an over-reliance on some of these safe harbor de-identification standards like the one in HIPAA. The problem with these standards, of course, is that they're very blunt instruments and they often strip some very, very useful information, regardless of whether or not stripping that information is strictly necessary to render something non-identifiable pursuant to the definition of identifiable information. Another area that we looked at with regard to the variation in these federal laws were the exceptions to disclosure without the consent of individuals. And the two exceptions we really focused in on were the public health disclosures for public health purposes and the disclosures for research purposes. And I must confess here that there is a bit of an error on the slides. The recent revisions to 42 CFR did include a research exception, and that is included actually now in your comment box. That's in 42 CFR section 2.52. But you can see here that there isn't consistency, and there aren't these common exceptions across these different privacy laws. And when we look at this exceptions for public health purposes or research purposes, these exceptions exist because some policymaker out there determined that these were good policy, potentially because there is an ethical justification for it. There is an ethical good in releasing information for public health purposes. There's an ethical good in releasing information for research purposes. And what's really interesting is if we look at these laws, these same ethical standards are not present in all of these different legal frameworks. Now, in addition to this federal variation, as Jennifer mentioned prior to me, there's also tremendous state-level variation. I've looked a lot at the governance frameworks for health information technology in the states, both for information, electronic health information generally, and for health information exchanges. And there's just tremendous variation at the state level as well. So when we talk about data protection regulations, we're not just talking about tremendous variation at the federal level, but we're talking about potential multiplicative variation at the state level as well. So, I argue that one of the reasons why cross-sectoral data sharing for public health purposes is so tremendously challenging is the fact that we don't have a unified framework for protecting sensitive information in the country. And I'd argue that this tremendous variation is a source for both real and perceived barriers to data sharing. When I talk about a real barrier, I'm saying there's an actual law that restricts the given use or disclosure. When I talk about a perceived barrier, I'm talking about this perception that individuals might have that some law out there exists that prohibits a use or disclosure. But regardless of whether it's real or perceived, these are both actual barriers that get in the way of cross-sectoral data sharing. And so what does this result in? When we don't know what the law actually says, we get sometimes hyper-conservative precautionary data stripping, where we remove many elements from the data out of fear that it might be, an identity might be reasonably inferred. And sometimes this really negatively affects the usefulness of the data. Common that we would also see when there's legal uncertainty, increased transaction costs for data sharing. And frequently we see that this legal uncertainty will actually impede and prevent legal data uses. All right, so let's take what we've talked about with the federal privacy protection framework, and let's look at an international example. Let's look at the European Union's General Data Protection Regulation. So you see here, it includes a very broad definition, and it is meant to apply to all personal data regardless of the sectors. So it's a uniform definition, right? But regardless, in addition to this uniform definition and this broad coverage of this regulation, it also includes common exceptions that apply uniformly, right? So, you know, we see this in recital 54, this idea that you know, processing data might be necessary without consent for public health purposes. We see it in Article 9 as well, that some of those restrictions on processing particularly sensitive data do not apply if the processing is for public health. We see that although there's this broad a restriction on processing information beyond the purpose for which that data was collected, there is also a broad exemption for scientific and historical research. So this scientific and historical research is not incompatible with the initial purpose. So again, broad coverage of this regulation, but also broad exemptions. It's a very different model, and you know, I'm not an expert in the GDPR, but and I don't profess to say that this is a better, that the specific contents are a better way forward, but it, as a model, as a unified and uniform model, it does certainly reduce the complexity that we have here in our federal framework. Right. So if we are to pave a path forward in this country in terms of supporting cross-sectoral data sharing, we need to get a better understanding of what the laws actually say, what they allow and what they restrict, and how we can use those legal tools to promote data sharing for public health purposes. So I look forward to your questions, and I'm going to pass it off now to Kathleen, who will show us talk about an example of successfully navigating some of these barriers to do some really tremendous things for public health. Thank you very much.
Thank you so much for joining us today. So my part, as Kason introduced, is a really fun and, quite frankly, we think really exciting example of trudging through all of the legal intricacies that Kason outlined to produce a practical product for use in our community. So this first slide here is an outline of how we started, where we came from. In 2016, Peoria County, where I worked at the city of Peoria within Peoria County, Illinois, got together with 2 partnering counties and decided to go through their health improvement plan as a group, as a collective. So throughout that process, we solicited feedback and looked at a bunch of data sets, as many of you may be aware of that process, and boiled the information down to 4 key public health priority areas for the Tri-County region, which were behavioral health, healthy eating, active living, cancer, and reproductive health. I specifically began participating in the behavioral health group, and here is just an infographic of some of our data. And as in many communities across the country, this really began the trend in focusing on behavioral health, compounded with the opioid crisis, with an uptick in suicides, particularly youth suicides. This was really a priority area for us. Some of the key statistics that I think are really amazing at the bottom, just above this pencil, is our ratio of population to mental health providers. And you can see that in Peoria County, there's 1 provider for every 490 people. So we had a lot of work to do. Within the behavioral health priority, we established a series of objectives and strategies to achieve our goal. And so I'll skip through this, but basically using evidence-based practices, we designed and identified what strategies we wanted to use, and we created our organizational structure. So the Umbrella Partnership for a Healthy Community was a board created from all 3 counties to support all of the priority areas. And within the Behavioral Health Committee, we formed 3 subcommittees, one for education and looking at trauma and social emotional well-being in schools, a healthcare component, which was tasked with implementing baseline screens in primary care offices and really trying to standardize intake and assessments across a variety of health systems. We had 3 hospitals in the area, plus an FQHC and the health department, et cetera. And then I chaired the Justice Committee, which we named the Criminal Justice Behavioral Health System Review, which very creatively is exactly what it says it is. And over the course of time, we had 2 projects within that committee as well. We formed a Narcan Advisory Committee whose task was to work on bulk procurement and a more systematic way of distributing Narcan effectively, and the High Utilizer Matrix team, which is what we will be talking about today. So within the Criminal Justice Behavioral Health System Review, we recruited a wide range of stakeholders. This, as you all know, social determinants of health cross all sectors and all stakeholders. And so when we formed, we made sure we had the fire department. We had 2 emergency departments from 2 hospitals in Peoria County. We had a judge who supervised our problem-solving courts. We recruited probation, staff from the sheriff's office and the jail, the police department, myself as the representative, our health department, and our homeless service providers through the continuum of care. They all had a stake in this because they all, as we were recruiting people and talking about behavioral health, we found that we all shared this common story. Our interaction with the individuals might vary slightly, but there were very common themes. And as we started talking about certain people without names, suddenly heads would start shaking around the table like we knew exactly who was being talked about. So the cycle with behavioral health and criminal justice interactions is classic. It might start off with something minor, something petty, for example, a criminal trespass, and a business or a citizen calls the police. Some of the behavior might be erratic, so law enforcement transport the individual to the hospital. The hospital feels it's not a medical issue, that actually it is just criminal behavior, and the appropriate response is arrest in the jail. After initial hearing, the judge is likely to be lenient, and the individual is released with a notice to appear. However, sure enough, this person is likely to reoffend, perhaps is trespassing again, and now that arrest is compounded. Not only did they fail to appear, but now they're trespassing. And so the cycle continues, bouncing between the hospital emergency department and the jail. And so we have these people who are consistently utilizing fairly costly services in our community. And we're all just trying to help, but everyone was really limited within their own worlds about what could be done. So we followed what's called the Sequential Intercept model, which was developed in the early 2000s as a tool to inform community-based responses to the involvement of people with mental health and substance use disorders in the criminal justice system. And this chart shows you our stakeholders compared to the intercepts along the model. So this actually really should be a circle when you think about it, but we chose to start at intercept 0 with the community and recruited stakeholders along the way. So we have our ambulance service and our behavioral health crisis unit there at intercept 0, as well as our United Way, which is the coordinator of the continuum of care, homeless services. As we move into preliminary contact with law enforcement, you also have the fire department, particularly if there's a behavioral health issue. They often responded as well. Between intercepts 1 and 2, we have our hospitals, because as I mentioned, sometimes that is the first response of officers wanting to ensure that the individual is well cared for and as healthy as possible. Then ultimately they are taken to jail, our sheriff's office down at the bottom. And while they're in jail and the court, once again, we have the Human Service Center as the behavioral health provider, both in the jail and in our problem-solving courts for drug court and mental health court. And then as we move to reentry, we have our probation office, and back into Intercept 5, back into the community, the Southside Office of a Concern is a supportive housing organization that works with the continuum of care, but specifically had some behavioral health treatment resources. So they joined our group specifically as well, not just as part of the continuum of care. So what we did with the sequential intercept model is we looked at the programming, diversions, and resources at each of these points. And we, tried to make sure that we had sufficiently robust diversion opportunities at each point. And as people fell through the cracks or were not eligible for the diversions early on, the diversions become more and more robust with increasing severity for eligibility. But we realized that in order to have really true, effective diversions, we needed to know what exactly we were talking about. There was a lot of stories, a lot of gossip, a lot of innuendo, but we didn't actually have hard numbers. So we didn't know if we were dealing with needs in the hundreds or if we were dealing with needs in the 10s or 20s. And so this is our timeline of work, slogging through to start to pinpoint exactly who it is we're talking about. As our health department administrator has been saying recently, we wanted to move to be performing surgery with a scalpel instead of an axe. But in order to get to that point, we had to overcome all the traditional barriers, not just the real and perceived legal barriers, but trust barriers. We had to establish common definitions. Everyone had a different interpretation of what certain terms might mean. We had to establish a common vision and just generally build this consensus that, moving to a more clear picture of who we are working with would help everyone. So we decided that we wanted to make a high utilizer matrix. And what that would do is tell us exactly who is using each service and if they're using more than one. And it took all of this time. We had a preliminary user matrix, but it ultimately fell apart due to trust and change in stakeholders, so we had to start over in May of 2017 there in the midpoint. And so even once we finally had buy-in from everyone, we did not actually have the resources for one person to compile all the data and run all the data. So in January of 2018, the health department hired an epidemiologist who also happened to be a nurse practitioner and who was very aware of population health and social determinants of health and jumped on board with this. And so finally, in mid-2018, we had our first matrix. And here is how we went about it. We decided that we would have two purposes with this information. The first would be in order to develop a community care plan to manage the treatment of the individual and prevent further use of emergency services. So each agency knew who their top utilizers were, and they had a plan in place within their agency for that individual. But little did they know, or there was nothing we could do about it, that same patient had a care plan with at least one or two other agencies as well. So you might have conflicting recommendations, conflicting medication, and of course, lower and lower compliance with those plans. So developing a community care plan was first. But in order to do that, we needed to know who we should find and work with first. And the second purpose was to elicit and build the political will, because we know that people are cycling through these systems and money talks. So if we could assign the financial dollar amount to this disconnected system, we felt that would leverage support to implement whatever evidence-based strategy we found after we had the data. So we had each of our stakeholders provide their list of high utilizers. We had first and last name. This is actually incorrect. We had age, not date of birth, an agency identifier if necessary, the number of contacts that that individual had with the agency. For the jail, we wanted additional information of the charge to see if there were any trends on that front, and we wanted to know the zip code. And so compiling all of this data from the first 4 agencies gave us a list of 315 people that crossed with 2 or more agencies in 1 year. The caveat to this that we learned after our first iteration and a recommendation that we would have is that the jail data is actually for 2 years, because when we pulled only data for 1 year, consistent with all the other agencies, we weren't seeing the numbers and the crosses that we expected, and that was, of course, because individuals were incarcerated at the time. So going back 2 years provided a more clear picture of that individual's history of frequent interactions with agency services. So as you can see here, of the 315, 250 high utilizers came from the jail, 29 from Human Service Center, 22 from AMT, and 11 from our fire EMS service. You'll notice that these are only 4 of our stakeholders while we had a much larger stakeholder group, and that was for a variety of reasons, primarily having to do with data security and information sharing laws. So these 4 agencies either had publicly available data that they shared, or they felt comfortable sending the data to the health department to serve as the central repository based on their authority as the health department and their role as also a behavioral health provider. So with these 4 agencies sending data to the health department, there was a continuity of care. The police department did not participate in sending data because their arrests were all sent to the jail. So the jail was the ultimate repository of that information. And here we have an example of our top 5 when we finally created the matrix. So as I said, we only captured people who had contacts with 2 or more of our partner agencies, and these were our top 5. So we started to get a picture and see a little bit who was intersecting where. And by the way, each agency defined their high utilizer in their own way. We did not set those terms for anyone. And another interesting exploration that we discovered over the 2 years came from the jail and how they defined high utilizers. They had created a flag report for their system for anyone who had any behavioral health diagnosis. And so initially they wanted to use those numbers, and then they reflected, no, they probably shouldn't release that specific behavioral health diagnosis. So instead, they ran a report on their number of bookings. And the individuals with the most bookings matched at 99% with the individuals who had the behavioral health diagnosis flag, which was interesting to know. But the data they shared was actually the individuals with the most bookings, so as to be in compliance. And so you can see this example of how the matrix looks. And what we did is we capped off the list, the 315. We distilled it down to 17 because there was really a drop-off in the number of contacts after 17. And then we sent that data to the hospital emergency departments. So they were not able to send their patients with admissions into the emergency department to the health department, but rather we sent them our list of 17 with the same information, first name, last name, age, and then the hospitals returned to the health department the aggregate admissions of those 17 people. So it was never specifically identified. And so that just made our list more robust. We could get more information. And from there, we did a very lowball estimate of the cost of each of those contacts. Each agency gave us their own price point for what a contact would cost. And those 17 people in 1 year cost our community over $3 million. And if anyone's sitting there with a calculator, we actually had an increase in one of the stakeholder dollar amounts that is not reflected in the total in red. So it's actually $3.14 million in 2017 in the city of Peoria specifically for 17 individuals cycling through these 6 agencies. We found that incredible. We thought the number was going to be high, but we were really blown away. And so we realized that we were going to have a strong message accompanying with this information. We could not just go to the media or go to our anchor institution leaders and say, oh my gosh, we have to do something, because everyone would respond in their own knee-jerk way, and we wanted to elicit a coordinated community response. So the plan was to take this information, and we had 3 recommendations. So we wanted to leverage that our current cost is over $3 million, so each of the primary stakeholders could invest a fraction of that to build an evidence-based practice at these 3 points. So first, we felt the need to expand capacity to engage at individual points of response, including on the street. So for example, perhaps having a behavioral health trained individual from the Human Service Center at the front doors of the emergency departments to be able to do a triage. No, you don't need an emergency room admission, or yes, you do, and what's the appropriate response. Secondly, we wanted to invest in case management. We wanted to have a caseworker who could coordinate the individual care plans that we created for those top 17 individuals and make sure that they're sticking to their care plans, that the appropriate releases were obtained in order to create the care plan and to track and monitor program success in this new coordination of care model. And thirdly, we wanted to develop a technology that would increase the quantity, quality, and frequency of data sharing in order to support these informed interventions. This simple matrix, these are the top 5, like I said, we ended up with 17, took over 2 years to create. Now we have the system down and we have the buy-in, but it still requires an epidemiologist at the health department to merge 4 Excel spreadsheets from 4 different agencies, send the information to the hospitals, and request our feedback each time we want to do a new iteration. It's very time intensive and of course prone to human error. So having a technology system in place, we feel would allow us to generate our lists more quickly. So once we had efficiently wrapped our top individuals in a coordinated care plan, we could rerun the list and find who else is rising to the top, who is a new high utilizer in our community, so we can initiate an intervention right away. So these are the recommendations that we have, and at this time, we are still in the political will phase, actually, trying to corral everyone who has an interest in this field to have this coordinated approach and to understand that the Criminal Justice Behavioral Health System Review Committee has already done the asset map and the research to know where our weaknesses are, particularly in the community, and that is why these are the 3 recommended responses. So I actually have since moved on from the city of Peoria, but I continue to be involved and help the generation of this list on a quarterly basis at this time. So here's my personal contact information if you have any specific questions for me. And that is the end of my presentation.
Okay, thank you to Kaysen and to Kathleen for the wonderful presentations. If you have any questions, we have 30 minutes available to us to ask questions of any of the presenters. You can open the Q&A panel and select all panelists and then type your question and click send. And then I will be able to ask the questions. So we do have a few that we got before the webinar. This one is for Kathleen. How did you overcome 42 CFR Part 2 and other privacy laws to achieve your project? To achieve the matrix is what you called it, right?
Yes. Thank you, Jennifer. That was very tricky and took a lot of time and discussion and, of course, consultations with attorneys. But basically, something that I might not have made clear in this is the matrix was de-identified to anyone who was not a behavioral health provider and HIPAA compliant. So, for example, when I worked at the police department, I never saw the names. I only saw that aggregate list of total contacts and cost. So the data was shared based on the definition of each agency of a high utilizer, not necessarily revealing any diagnosis one way or the other. And the information was sent to the epidemiologist at the health department based on their authority as a data convener and within that continuity of care. For example, that's why the sheriff's office had to change the data source that they used. They could not use the behavioral health flag, of course, but instead changed their report to the individuals with the highest number of bookings. And so that was the source of our data.
Okay. Kaysen, can you tell us where can we obtain the snapshots that you talked about in your presentation?
Sure, I'm happy to. I will post that. Of course, the slides will be available after the conclusion of the webinar at some date. I don't know, but in the chat window right now, I'm posting the hyperlink directly to those snapshots, and so you can scroll through and take a look at the ones that are there. I hope they're useful.
Okay, we're starting to get a few questions in the chat box. We have one that says, my community is attempting to create a post-overdose response for follow-up after an overdose, but we continue to run into issues with information sharing due to HIPAA and CHRIA, which is a Pennsylvania state law. Any suggestions? So I will just chime in that the Network for Public Health Law provides free legal technical assistance, and without knowing exactly what kind of challenges you're having with HIPAA, I don't know that we can give a lot of suggestions in the context of the webinar, but feel free to send a request to the network and we can work with you to come up with potential solutions or ideas about how you might be able to overcome issues. I'm personally not familiar with the Pennsylvania state law, but I do work a lot on HIPAA issues, and so we can definitely work with your community to address your desire for an overdose response. There are some good examples of those types of projects in other communities. I know that the city of Lansing in Michigan has an overdose response collaborative, and they do share identifiable information between agencies, so they have overcome issues like that. I don't know if any of the other speakers want to comment on that. Okay, so we'll move to the next one. What do you envision? I guess this is for Kathleen. Is there anything you would do differently having gone through the process the way you did in Peoria?
Yes, but I don't know if we would have gotten to where we are if we hadn't gone through all the struggles and everything. I would say that it depends on where your resistance points are. For us, we have two large hospital systems who are right across the street from each other, and they are literally in constant competition for patients and for funding. And so even though they have a shared electronic medical records and the health exchange, they were each really trying to work as the primary in the care planning aspect. And so for them, we had to approach it from, how many people are you seeing time and time again? And the Affordable Care Act really helped us in that, they had to reduce the number of readmissions that they're seeing. So we were kind of able to leverage from their perspective, but it took us a while to get to that point. And instead of just coming right out of the gate and saying, we know you're having multiple readmissions, we know that's a cost issue for you and a top priority for you, so can we start working on the care plan? And we also struggled with them in receiving their data. And so just right out of the gate, if we hadn't even considered them and asked them to send their data initially to the health department, just automatically gone to, we're just going to send you our list and you can send it back aggregate. I think that would have saved us like 6 months of legal wrangling back and forth.
Okay, here's another question. What would be the easiest fix for data sharing that could be done immediately and in the future if money was no object? What changes do we need to see in the future to fix data sharing? I don't know if, Kaysen, you have thoughts on that?
Yeah, I mean, I think we need to do better at understanding the laws that regulate data use and data disclosure. I mean, I feel like we all hear time and time again complaints about how HIPAA just ruins everything and prevents all sorts of data sharing. But the reality is that HIPAA's got some pretty broad exceptions that allow a lot of the data use and data disclosures that that are beneficial for research and public health. So it's an issue of understanding, which is an issue of not having access to good legal counsel. Or not being willing to engage the legal counsel that you do have to identify those issues and identify the appropriate legal mechanisms to facilitate data use. And going beyond the law, I think Kathleen raised a really important point about relationships and trust. And sometimes the barrier that we're blaming on the law isn't a legal barrier, but it's just a manifestation on the fact that there isn't a strong enough relationship between the data holder and the data recipient, and for there to be any sort of meaningful data sharing, that relationship needs to be established. So sometimes it's important for us to realize when we're dealing with a legal issue or when we're dealing with some other issue that is just masquerading as a legal issue.
And I'll add to that. I think I was intrigued by the idea that money was no object in the person's question, and I don't necessarily think that money is always the solution to data sharing. Obviously, it can aid in allowing you to have access to legal counsel and things that can be really helpful. But in Kathleen's project, they used Excel spreadsheets to develop their matrix. It was very low budget, and it was really about the relationships that they built, as Kaysen was saying, that you have to establish trust. And I think that these things can be achieved even in lower resource communities. Okay, and I think that this next one, I think, is a great follow-up. Were there any particular arguments for data sharing that you found to be particularly effective for stakeholders to participate? Like, that's directed at you, Kathleen.
I sort of mentioned it in answering the last question, but there were different arguments depending on the stakeholder perspective. So The healthcare providers and the hospitals were already feeling the pressure from the Affordable Care Act and had established behavioral health as a top priority. So for them, sort of guaranteeing that the rest of us in the community would step up and try to help people from not coming into their emergency room was huge. They didn't want their hallways filled with people who were intoxicated. And so it was, if we have this information and we develop a care plan, which can only be created with consent of the patient, which is why we had to know who the patient was in order to create the care plan, and hopefully the consent would include law enforcement at that point. So if everyone knows the individual, they know what's going on, then you won't have that knee-jerk reaction of, oh, let's just dump them in the emergency room. So they love that. For the sheriff's office, very similar. We don't want to keep getting these low-risk offenders who aren't really here for anything more than being cold and trespassing or being homeless. We don't want to criminalize homelessness. There has to be more treatment options. And so when we could say, if we have this information and we know how much it's costing all of us, we can dedicate those resources to improving care and improving access and increasing access. So that was a win for them. Same with the police department, even though they weren't a component of sharing data and they weren't receiving data yet, they genuinely wanted more resources in their tool belt. They didn't want to have to just only arrest or only send to the emergency room because they're spending hours babysitting the patient. And so framing it that way really made it a win-win-win for folks. And those of us in public policy got the satisfaction of finally seeing things coordinated and a more efficient use of resources, hopefully, at the end.
I'll add that I think that when you are developing a data sharing collaborative, finding the benefit for each of the parties, as Kathleen was saying, is really going to be the compelling factor for people to participate. And it doesn't always have to be a direct benefit to that stakeholder. It could be something more indirect, but that either saves time or resources for that organization, or benefits the community at large, that has an indirect benefit for that group. And so framing things in that way, and benefit doesn't have to just be monetary as well. There's a lot of other ways that there could be benefit. So looking for those arguments and as we said before, building up trust between the groups is helpful. Okay. Another question for Kathleen. When you mentioned the epidemiologists merged the data, were they able to see all of the detailed data in order to perform their work, or did they only see de-identified information?
They did have identified information, which again was last name, first name, age, zip code, and extra details as far as like charges and things like that from the sheriff's office. So there was no diagnosis, no case notes, nothing like that, but they did get names, age, and zip code.
And the epidemiologist was part of the health department who was working
Correct.
as the clearinghouse in this situation, right?
Mm-hmm. Yes. Okay.
Great. And so I think that the next question that might come to people's mind is, well, how does that work within a legal structure? And I imagine, though I'm not the attorney for the Peoria project, that they were using a HIPAA exception for public health in order to do that work with the identifiable information.
Which was accepted by the first 4 agencies, but not by the hospitals, which is why the epidemiologist did get de-identified aggregate data only from the hospitals on the emergency department.
So that's another way that we can come up with creative solutions. So if certain organizations within the collaborative don't want to share identifiable data, then they can do the work themselves of de-identifying and aggregating the data to feel comfortable in sharing it. Always coming with creative solutions. And just, I think one of the key things is keeping the ultimate goal in mind. If de-identified data is enough to get to that goal, then that a lot of times can alleviate some of the legal concerns, and you can still come out with a good product that can have benefit to the community.
Yes. I would mention also, and this sort of relates to the overdose response question, is look to see what's publicly available. You know, an individual who's overdosing has contact most likely with at least 3 agencies. So if, say, the last point of contact is the hospital, they might not be willing to share, but usually there's a police response or a fire EMS response of some kind. So the incident is logged in public information. And the charge might not be very specific, but you'll find certain charges associated with an overdose that you could sort of peek behind the curtain to understand what was going on, if that makes sense. Or using frequent addresses for dispatches. So maybe you don't have the person, but you have a location where overdoses frequently occur. That can help you target resources without needing patient names.
Okay. Another question. In research, individually identifiable information is definitely the new wave in research. There are times that principal investigators are just fearful to incorporate this data into their research when it is the most beneficial. What do you suggest? I don't have a lot of experience with academic research data, but I don't know if Kaysen has any thoughts on this?
Sure, I'm happy to share my thoughts. So one of the things that drives me up the wall is when there's confusion applying. I mean, I had a slide on this about the different identifiability standards between different federal laws. What I see time and time again is confusion about what definition applies in a given context. And the rule for the common rule for what constitutes, in that case, it's identifiable private information, but it's where the identity of a subject is or may be readily ascertained. So that ready ascertainment, you know, if you look at the definition, we're talking about something that can be easily determined. Yet I see time and time again when research bodies are applying a much higher standard when it comes to identifiability. So again, you see this time and time again where researchers are forced to overstrip data in order to comply with what really isn't a legal standard at all, but it is just the comfort level of the body that is making the determination about whether or not to approve the research. So I may have gone a little bit on a rant there, but and lost track of the question. So please steer me back if that was the case. But paying attention to the specific definitions and about what definition applies in what context is really, really important, and that is a way to facilitate data being used for research purposes. And having those discussions with, the privacy board or the institutional review board, can be beneficial. Sometimes it can feel like you're talking to a brick wall, but it can be beneficial.
I feel like that was said by a true professor, someone who's dealt with these issues. Okay, so we have another question. I think this is directed at Kaysen. What do you envision that a GDPR type framework could look like in the U.S.?
Right. So, that's a really, really tricky question. My hope is that some of, we are actually seeing the opening of a policy window, of opportunity to change federal privacy law. And this is occurring due to, a lot of these high-profile breaches that you see primarily in the tech sector, some at the financial sector. But the public is starting to get pretty fed up with this, and lawmakers are starting to take note. So there are two things that we could see happen. One, we can see a continuation of the way we've always done things, where we slap another patch onto the quilt and have a new privacy law that just relates to big tech firms or these financial industries, and that way we just making our federal patchwork of privacy laws one patch more complicated. Alternatively, we could take a step back and look at the entire framework for how we're protecting our data and try to figure out what is the appropriate balance between the various ethical principles that we as a society want to give various weights, whether it's autonomy, justice, beneficence, social and public good, and figure out what the appropriate balance is, and then root our policy in those ethical principles. I think the first step is having a real serious discussion about what we want to do in terms of protecting sensitive data and what uses we want to permit and encourage within the law. So, the first step is if we're going to look at a similar approach to the European Union that is going to cover everything, then we need to take a long, hard look about what sort of ethical principles we want to ground that policy in. And that is going to dictate what sort of exceptions to a broad general rule protecting all data we want to permit.
Okay, I think that's all the questions that we received, and I want to thank
Jennifer?
Oh, yes.
I did see one little note asking for an example on related to nutrition. And
okay, I missed that. Do you have any examples?
Yeah, I actually do. I'm gonna put this in the chat window. There is a wonderful resource that was published by the Administration for Children and Families, and this is going into the chat window right now. But this resource went out in 2014, and it goes law by law protecting privacy in various contexts, including nutritional programs, federal nutritional programs, and it talks about how you might institute data sharing in this context. And importantly, it helps you make the case, make the argument for sharing. So it's a really terrific resource. It covers just a huge number of different data protection frameworks and laws. It's, regardless, it's not restricted to nutrition. It's worth a look. It's a terrific resource. Good luck.
Okay. Well, that, I think, was all the questions that we received. We are very thankful for all of you attending through the entire webinar and providing us with some great questions. I want to thank Kaysen and Kathleen for agreeing to present on this webinar. And for a recording and to get slides for the webinar, you can go to the Network for Public Health, network4phl.org/webinars. And you can also go there to sign up for our upcoming webinar, which is Intimate Partner Violence in the LGBTQ Community, examining the legal, the practical, and the real-world challenges facing survivors, and that will be on March 28th. So thank you all for attending, and have a wonderful day.